Recording in progress.
Right, pour it in.
Recording in progress.
All right, so we're going to go ahead and get started.
Just co-host so I can monitor.
I would love to. Thank you for the gentle reminder. And hello, Miss Erica.
Hello, Tina. Hello, everybody.
Yes.
Good evening. Good day.
Wherever you are in the world, right?
Yeah.
Okay, awesome. Appreciated. Perfect. Thank you so much. Housekeeping stay videos on, please, unless you're driving. See your face and see your engagement and know what you look like. And muted unless you have a question. Go ahead and raise your hand. The typical stuff, right? We might have comments, so we're going to make sure that we don't capitalize on all that we want to share in the chat. Go ahead. Erica will prompt you guys to put some stuff off. You can put question there if you're concerned about saying it out loud. Erica will be your voice. So let's get jumping. My name is Tina Hurley. I'm the founder and executive director of Less Leg More Heart, a national nonprofit that provides support, supplies, and services to improve amputees. It's intentionally vague. We do a lot of different things. Always looking for volunteers, always for donors. Anyone that needs help can come to our amputee in need form on our contact page of the website, lesslegmoreheart.com. But this forum, this Heart to Heart, is our peer group meeting that meets the second Thursday of every month, where we bring health and wellness and limb loss experts to the comfort of your own home to help you live your life and put your best foot forward if you have one left. And tonight is really exciting. We've got an amazing expert that is going to lessen our ignorance on some perception about out there in the world. So without further ado, we have tonight Professor Dr. Munjed. He is a very, very well-regarded physician, and he's a technical and technological pioneer in the field of osseointegration, leading specialist in limb reconstruction, limb lengthening, and deformity correction. Of the Royal Australian College of Surgeons, he holds a medical science on the subject of osseointegration from the University of Australia, and has made significant academic research and clinical practices around amputee care as a clinical professor at some of Australia's most prestigious learning institutions. Florida at this time at Paley Institute. He's one of the handful of specialists experienced in both above and amputation and osseointegration. Professor Munjed has additional expertise in the use of procedures, including RPNI, which is regenerative peripheral nerve interface, and TMR, targeted muscle reinnervation, and it can help to reduce neuropathic phantom sensations in patients that are living with limb loss. That is an very abbreviated and condensed bio for some. You could fill probably an entire book of their accolades with. So without further ado, I would love you, Dr. Jed, to say hello and to speak about one of your passions. Thank you so much for being here. It's a pleasure to have you.
Thank you very much to be here. Thanks for inviting me to talk. And I'm more than happy to have this session as dynamic and as live as possible. So if someone want to or ask a question, and if you have something you want to say, please say it, and I'm happy to answer any questions, as complex, as critical, as difficult as they are. My name is Munjed. I'm an orthopedic surgeon. I in Iraq and lived 27 years in Iraq, and then I had to flee of Saddam's regimes, and I ended up being on a boat to Australia. I spent a year in detention center, and then I was released. I pursued my passion about doing surgery, and particularly orthopedic surgery. Had a dream when I was a young teenager to do human heart machine. In 1984, I watched The Terminator, and that movie inspired. I went and did post qualification studies in Germany, and I learned the integration surgery for amputees. And then I brought it back to Australia. So what I've done is I studied the German technique, which is a press fit technique based on hip replacement, and I practiced it in Germany, and then I came back and I studied with the Swedish system with a screw fixation device. When I went back to Australia, I decided I want to make changes to it. So I'll talk about Osseointegration and where it started, and how it started, and people who have influenced the where it is now, and where it will be heading in the future. So first, we acknowledge people like Amba Varé, who's a naval surgeon from France. He in 1529, the 16th century, he invented the socket-mounted prostheses. Basically, this technology allowed people with limb loss to mobilize again, and this technology is used to this day. So long-lasting technology with a socket-mounted prosthesis. Until 40 or 50 years ago, the socket was made out of carbon wood. But more recently, with the introduction of carbon molded plastic and now 3D printed technology, people are making socket prostheses with more modern kind of material. Socket mounted prosthesis is a suspension. It's like a bucket that wraps around the residual limb, and it includes tissue and the skin, and hang there. And there are different types and different fancy names that are coming out of it, like socketless socket, etc. But basically, the phenomenon is either a piston centralizer that centralize the, or it's a suction fit. These are the two main, basically, modalities that are available. What it has is many benefits by allowing the patient to put weight through that and attach it to a prosthetic limb, and to walk in upper limb. It is less reliable because it's a bended device, so you need straps to attach it. Like majority of people with upper limb sockets, they abandon it because they become dexterous and walk in their arms. So it does have its drawbacks. The drawbacks are three types. One is the soft tissue or the skin socket interface problem, and that involves the friction, the blisters, the ulcerations, the basically abscess, ingrown hairs, chafing in hot environments, sweating, and heat. It's like a thermostat. That's one problem. The second problem is the mobility of it. Our body change during the day. In the morning, body is less swollen, less fat, less fluid in the fat tissue. So basically, it becomes loose, and then at the end of the day, our body swells, so it becomes tight. Females with a monthly cycle, it can vary. With seasonal variation, it's a bit roomy, and summer it's too tight. So that's the mobility and fit issue, and lead to loss of energy. The third problem with the socket is lack of proprioception. You don't feel the grass like a hover mat. So these are the drawbacks of the socket, and the advantage is that it does allow the patient to walk. What osseointegration bring is basically a revolutionary technology that eliminate the socket. This is not new. It started in the 60s with Bangava Brahmamak. The father, who's a scientist, was doing kidney blood flow. He on a rabbit tibia, and then he put a titanium implant into the tibia, and then when he tried it after the experiment finished, he noticed that bone grew on that screw. So he coined the term osseointegration, basically bone growing on an implant. From there, ideas came that the titanium is biocompatible, and then it developed the dental technology, and it becomes more widely used. Dental implants, I have two actually, osseointegration implants that have been sitting there for many years. And the mouth is the dirtiest part of our body. Has a lot of bacteria, but surprisingly, it doesn't get infected. And the reason is, as long as there is an opening, it keeps leaking, it doesn't collect, it doesn't form an abscess, so bacteria tend to use the easy passage. In 1990, a lady who had bilateral above knee amputation called Pangava Branham and asked him to put two titanium dental legs, and that happened, and designed a dental implant into the femurs. And this lady had the osseointegration device for into her legs, and that lasted 24 years. So the concept does work in limbs. It is basically a piece of metal that's inserted into the hollow part of the femur or the tibia, and it is connected to a prosthesis through a small opening in the skin. That technology become more used in more patients, and then the Germans basically developed another technology utilizing what's available in the arthroplasty by a press-fit implant, but it was made of cold. But this was just hammering the implant into the cavity femur or the tibia, and mainly the femur, because nobody wanted to touch tibias at that time. For many reasons. One of them is a reverse pyramid, and we didn't have the implant for it, and many of transtibial amputees do okay with a socket. So people avoided doing tibias and concentrated on doing femurs. So that become more used. The problem that we had with they were two-stage surgeries, and there is a reason. The first is that the opera system is a screw fixation device, so you need time for the bone to grow into it. It's a good system, but you need time in the healing and allowing the loading, so it's two-stage. And the old theory was thinking that if you do it as stage, you reduce the chance of infection. The German system is press-fit, but also didn't move into one operation. When I came back from Germany, I thought that this is problematic because 6 months or a year is a long time of a life of an amputee, and especially if they have to be in a wheelchair between stage 1 and stage 2. So I decided to develop an implant that would allow single-stage surgery and do one operation. I was heavily criticized at the beginning that infection rate will be higher, and I'm embarking on the unknown. But the science that I worked on is that hip replacement, we get the patient up and going the same day of the surgery. We use press titanium, so I designed an implant that looks like a hip replacement implant. It is It has a proximal fins that allow cutting into the bone, provide rotational instability. It does have a collar that allows axial loading and prevents subsidence, and it has a distal inductive and osteoconductive surface with macropores that allow the bone to heal inside the implant with time. And it has enough length that allows the bone to heal over it. So if there is bone resorption, it doesn't get affected. So, and I started in 2014 using single stage surgery and never moved back since then. And now, in the last consensus meeting that we had in Sweden, everybody agreed that the future is for single stage surgery. Finally, but it took more than 10 years for the rest of the community to accept it. Basically, we have done now over 1,000 osseointegration implant using the press fit device, and by doing single stage surgery, everybody now is moving to do single stage surgery. And it's becoming more popular and more available to people and more widely used. Now, there is always the fear that we had in the past about infection. And what we noticed is that over the last 5 or 6 years, we have gained significant amount of maturity and understanding about how to handle the soft tissue, to handle the bone implant interface. Seriously, we're not seeing the number of infections that we used to see back in the days, and it's becoming less of an issue. That doesn't mean that this technology is bulletproof and complication free. I'm not saying that with any kind of technology there are drawbacks. It is still a piece of metal sticking out of the skin. It still have the area where there will be leakage, and it varies from one person to the other and depends on how the surgical technique is done. Some people ooze more, still are prone to developing granulation tissue or overgranulation that may need treatment. People can develop overhanging of soft tissue, and that may require basically refashioning. And there are other things as with amputation itself, and they are like the neuropathic pain, the phantom limb pain, and these things are not solved by the osseointegration surgery itself. But there is a solution for them, which is the TMR or RPNI. I moved away from TMR completely. Now I do mainly RPNI for amputees, for people who have intact leg, TMR on occasions. But RPNI, in my hands, I've noticed that it has much more predictable value and much better results than we used to have with the TMR. But it doesn't. Again, it's not a bulletproof. Unfortunately, with amputation, we are dealing with optimizing the comps, basically, because we're not dealing with an intact limb. We're dealing with a compromised situation that we have to work around it in order to optimize for the patient or the person to mobilize as good as possible. However, I always say to my patients, there are 5 methods of treating amputation. Number one, well, 3 of the methods are available and 2 are fictional. And I'll talk about the fictional first. The growing a limb, we don't have the gene yet like a lizard. And maybe one day we will discover that gene and be able to code it and then grow a limb after we lose a limb. That's in the unknown. Transplant a limb, and unfortunately, limb transplant. I get asked a lot of the time, limb transplantation. It is more successful in toe to thumb transplantation, but with full hand or full arm or full leg transplantation, the number of cases that have been done on hand transplantation are handful of cases and are not predictable. With lower limb transplantation, there have been a couple been done, from my understanding, in Italy, and basically they these cases were purely for cosmetic reasons, and people have to go on rejection and immune suppressions. The most successful and most safe method treatment of amputation is a wheelchair, believe it or not. A wheelchair will have less infection problems, less chance of fractures, less chance of any complications, less chance of infections. However, a wheelchair does not provide a person with a proper mobility. Osseointegration, on the other hand, gives you the maximum mobility compared to a socket, but it has its own complications. And the socket-mounted prosthesis is between the wheelchair and the osseointegration. So this is where we stand at the moment. Now, what is happening with the osseointegration nowadays? It's becoming more and more popular, and people are less resistant. The more awareness that patients have, the more number of people that have them, more clinicians know how to deal with them, and it's becoming not the big wow factor in a positive and a negative way. And I think in the future will become more standardized in the world of limb loss. Where the future holds, future will hold that there will be more and more below knee amputees using osseointegration surgery. There will be more patients going from amputee to osseointegration. I was one of the first people that started doing that, and we've done over 50 cases. And the advantage of going from amputation to osseointegration directly is that people will not get the osteoporosis, they will not muscles, and they will not learn bad habits of the gait alteration with the socket. The disadvantage, though, is people don't appreciate osseointegration because they go from able body to osseointegration. With mobility, they will still be inferior to an able body, so they cannot compare it to a reference with the problems with the socket. So sometimes patients do feel that they still not perfectly mobile, and some people psychologically are not ready for embarking on osseointegration surgery. More patients will be accepting transtibial osseointegration, especially now the design and the implants that we have are much more robust. And now there are people coming up with all sorts of 3D prints like that. I moved away from 3D printed implants for a reason, because we started having fractures of the implants 2 or 3 or 4 years later down the track, and we're publishing a couple of papers on those. I stick with 4 very stable with coarse surface. Do possible soft tissue management, prepare the patient from their social surrounding, and optimize them for the surgery. Patients need to be followed up with osseointegral basis. There are components that need to be resurfaced and replaced. There are components that get worn out, similar to anything with a prosthesis, and that doesn't mean that the patient, once they get osseointegration, that's it. It's the end of the follow-up. They need to be followed on long-term basis. Where the future holds, I think the future will have. We're working on developing smart implants, and the smart implants will have sensors in them that can detect and detect loosening and detect fractures. And this technology is available to us now, and it can't. The other thing is that implants that can have sensors inside them that can measure the activity level and the gait cycle, and that can be internal or external, like podometer. And the third thing is that what we're working on is that we get smart that can treat infection. So if you get an infection, change the pH, and or you can use an ultrasonic device on top, and that can emit basically hydroxide, for example, and that can alter the pH or treat the infection one way or another. There are certain oxidized surfaces that can be bacterial repellent, and what we use now is titanium nitrate surface that bacterial repellent that reduce the chance of them. Some people have used silver coating. I'm not that favor of silver coating because it turns black and it can become not cosmetically appealing. It can ruin clothes and things like that, and it's very difficult to look after it. Another technology that is evolving, and we have done few cases so far, is implementing implantable electrodes into the body, and that can operate on my electric prosthesis like a robotic device, motorized. Because majority of the limbs that are available are passive limbs with gyroscopes, but implementing motorized prostheses in the future with better batteries, better motors, that can be a game changer in the future, which would help the patient to go upstairs, can flex and extend their ankles. That can be revolutionary in the future. It is happening. It's just a matter of engineering. I think I sums all together, and I'm happy to take questions now, if that's all right.
Yes, that was wonderful. Thank you so much for the information. I know it's like water from a fire. Those are those of us that are learning as we go. I would love to just take a moment quick, Erica, get caught up on the chat first, and then when you're done, we can start calling some hands.
Okay, perfect. So Kevin Gray asks, can a bilateral below the knee of an OI, considering this person is a diabetic, and then also, are there concerns about bone density?
Yeah, this is an excellent question. I started doing diabetic patients in around 2015, and we have published 2 papers so far on this vascular disease and diabetic patients, one of which is 10-year follow-up on a patient who was 74 when his operation. He's 84 now. We thought initially that diabetic patients are contraindication, and obviously when I came and took this task of taking osseointegration further, I embarked on single-stage surgery, started doing smokers, and started doing diabetics and vascular patients. And what we noticed is that diabetics don't do worse than general population as long as the diabetes is under control. If the HbA1c is below 8, it's doable, and the risks associated with diabetes is not higher than with traumatic amputees. And the reason is, with traumatic amputees, they have high activity, so they are prone to have more complications due to activity level. While the diabetics, they just want to walk. They're usually lower level of activity, so they are less prone to traumatic incidences, but they are more prone to bone loosening or infection. However, the traumatic amputees, because of their level of activities, they get more inflammation and they may get more infection. So it's a balance. Okay. So to answer the question in two folds. Number one, diabetics are not contraindicated in my books, and I do diabetic patients. Diabetics have not shown higher incidence from the literature that we have published and from our data when compared to traumatic and or other type of amputees. Now, when it comes to bilateral patients, that's more so of an indication rather than a contraindication, because with bilateral amputation, the chances of being successful socket users is low. So, especially above knee amputees, bilateral above knee amputees do way better with osseointegration, whether they're diabetics or not. So, in summary, there is no contraindication, and yes, bilateral below knees with diabetes can have it as long as they have controlled diabetes. Now, the answer about bone resorption and osteoporosis, if you load bone, will slow, is very clear. You load bone, you form bone. If the bone is not loaded, does not, it becomes osteoporotic. By definition, you do osseointegration on a patient, that bone will be biologically and mechanically loaded as it was before the amputation, and that will form bone. So it will off bone density. Now, is osteoporosis or poor bone quality a contraindication for osseointegration? No, it's not. As a matter of fact, it is advisable that patients have osseointegration, osteoporosis, in order to reverse that cycle. We published, I think, 4 papers on that subject.
Wonderful. All right, next up. Yeah.
So Matt C from New York City says, I'm an amputee because of an infected knee replacement. And his doctor is very fearful of integration for that reason. So are previous infections indicative of long-term issues?
Well, this question is very important as well, because we have done and published a paper on infective amputation or amputation due to infection. The answer is that there is definitely no correlation between the infected and osseointegration as long as the infection has been cured. Okay. Now, if the amputation has achieved and the patient is infection free, with these kind of scenarios, I usually stage the operation, go in, curate the canal, remit, put an antibiotic spacer to the lab, and then wait for the results, and then come and do the implantation. And once everything is clear, there is definitely no correlation between the two as long as the infection has been eradicated. And you presume that with an amputation, the infection is eradicated. Are these patients likely to have infection? It depends on their immune condition. It depends on their infection susceptibility. Why did they have the infection beforehand with the replacement? Was it iatrogenic infection? I mean, surgery itself? Was it due to a bug that got into the circulation? Was it due to immune deficiency? If it is the case with immune deficiency, then yes, comparatively speaking, these patients will be more prone to develop infection regardless, such as people with diabetes, people who have this vascular disorder, people who smoke, people who take immune suppression, such as medications, such as steroids. This would put them at a higher risk of developing infection. If that answers the question.
Thank you. Kevin asks, and Nico, I saw your question. I promise I'll give you a turn. But Nico asks, I have surgery in 6 weeks. This is Kevin, sorry. What is the most important thing I need to do in the meantime? Diet, exercise, mental prep, preventing skin breakdown.
So, ideal world, definitely you should optimize your weight. Weight is very important. We published a landmark paper in 2016 about the safety of osseointegration and found that the higher risk of patients are females, obese, smokers. Okay, so obesity is directly correlated. Smoking is directly correlated. Being a female is directly correlated to postoperative infection. So optimize your weight. The less fat, the less adipose tissue, the less chance you will get an infection. Eat healthy diet. Do not become a vegetarian because you need proteins and you need the proteins in the meat. Basically quit any kind of nicotine intake, whether it's smoking, whether it's vaping. All of these are factors that adversely influence the outcome. Assessment and psychology preparation is very important. Surround yourself with family members that understand, that can support you, and it is not a bad idea to have a psychologist to be on board to help you through the journey.
So another question for amputees who may be hearing about osseointegration, how do you explain at a high level what makes it fundamentally different from traditional socket prosthetics? For example, which amputees tend to benefit the most from osseointegration, and who may not be an ideal candidates?
So the best patients that benefit from osseointegrations are above knee amputees, followed by single above knee amputee, followed by transtibial amputees, thumb amputees, transhumeral amputees. These are the people that would benefit from it. People who have short residuum, they would benefit from osseointegration because they would have struggle with the socket. People who have significant skin graft, scarring, people who have delicate skin, people who have allergy to silicone liners, people who develop neuromas, people who have significant heterotropic bone ossification or bone spurs, and people who have significant soft tissue issues. These are all patients that would benefit highly from osseointegration surgery. I see 4 types of patients, and one of them is the patient that you should never get the operation, okay, and unless they completely transform their life. So patient number 1 are patients who are wheelchair bound, and these patients you can help a lot because you can give them the mobility that they deserve. Patient number 2 are the patients who are using a socket but have issues with the sockets, the socket issues that I mentioned before. These are the patients that you need to basically counsel very carefully about the benefits and the risks, and ultimately they need to make that decision. Patient number are the patients who are very good socket users and have minimal problems with the socket, but they just want a better quality of life. These are the patients that would benefit from osseointegration to mobility. However, if something goes wrong, they can go downhill. So you have a very valid reason why they would go through this process, especially it's a major surgery, significant work, and if they're doing well with the socket, they should the devil that you know is better than the devil that they don't know. And these are the patients that I would urge them from having the surgery just because they want a bit better. Okay. Now we have patient number 4. Patient is the patient that the minute they enter the room, and I'm very blunt and I say it as it is. People sometimes appreciate, people don't appreciate it. World for their problems, and the minute they get to the room and they say, "This guy stuffed me up. This guy stuffed me up. This guy stuffed me up. I can't. My prosthetist don't know what to do. My physio don't know what to do. I'm, my wife left me because she hates me, and try to find excuses around them for the problem rather than focus on the solution. These are the patients that need to have significant reconsideration because osseointegration will not get them out of that situation. And they need to help themselves improve because no matter what solution you is there for them, these patients will not get better. The problem will transmit from problem with share to the problem with the socket to the problem with osseointegration. And a patient to and this can be helped. They just need proper counseling, psychological assessment, and help out of the situation, the box that they are in, into the area where they're focused on solutions rather than problems. So you may have heard me by saying psychology is very important for patients. Patient need to be driven. Patient need to, wanting to get better, and it takes two to tango. It can put the best implant in the patient, the best leg, but the patient still do not walk because they don't have the will to walk. So now there are certain contraindications, and I'm the person that broke a lot of barriers and crossed a lot of lines that are not crossed before, such as doing dialytics, doing peripheral disease, doing single stage, doing younger patients now. But there are certain things that do not have surgery with them, with their situation. Irradiated bone should not have osseointegration in that bone because that bone is dead. Patients who are receiving chemotherapy should wait until they're completely finished. Patients should, who are double transplants, like kidney, pancreas, if they are on immune suppression and they have kidney, heart, pancreas transplant, lung transplant, these patients may not have a problem with the integration itself, but if an infection happened and if it goes and kill their organ transplanted, then you would not do them a favor. So in my books, these patients are, and I advise them not to have it done. Patients clearly who are psychologically unstable, they should not have the surgery. Apart from that, pregnancies and other contraindication. The person need to finish with the pregnancy to consider it.
So off of that is the issue with becoming pregnant.
We had several, as a matter of fact, I had patients that came, moved from a socket to osseointegration because they wanted more kids, because every time they get pregnant, they can't wear the socket because their body feel weight and change, and that becomes a problem.
So Matt, again from New York, says, I had radiation treatment for prostate cancer, sorry. And October, hormone treatment finished in December. Do those cause any concern?
Sorry, can you repeat that?
Yeah, it's okay. No, Matt C from New York City again. I had radiation treatment, prostate cancer, which ended last October. Hormone treatment finished December.
No, if the radiation did not involve the bone that is going to be implanted. It's a radiation to that bone. it's radiation to the rest of the body.
Perfect. Okay, so your work has enabled single stage osteointegration surgery. What does that change for patients compared to older multi-stage approaches?
Yeah, look, and bright approaches. I had one dental implant with two-stage surgery, and I had another dental implant with single-stage surgery. Even dental implant technology has moved to single-stage surgery nowadays. For me, it depends on what implants you're using. There are certain implants that doesn't allow single-stage surgery, but I can't comment on that because I can talk about the implant that I just. There are certain implants that doesn't allow single-stage surgery because it doesn't have the ability to have bone and growth quickly, and it doesn't have the provide initial stability. You need an implant that is initially. Is single-stage surgery better than two-stage surgery? Look, people ask me that question all the time. The literature is written by people like we write the papers. We are the ones who are pioneering this this process. And majority of the papers that are written by myself, Mark, and a few others. You get the largest number of patients. Now, am I an expert? I'm far from it. Okay. Do I know everything? Do I know most of things? Do I know some things about osseointegration? No, I don't. We're still exploring. We're still learning. We still find out from our experience. So, yes, we are writing the literature. Yes, we are the most experienced in this field. Yes, we have done numbers. And yes, we are developing this technology as we go. But are we competent 100%? Definitely. I would recommend people, if they want to have a guaranteed outcome, come back in 50 years. Okay, then you will have what had in the 60s with hip replacements. Like Sir Charlie in the UK, when he invented the modern hip replacement technology in 1962, everybody criticized him. He was crucified for using the technique that he did. Okay, and now track. Okay, we all follow what he did, and the principles, and it become like common practice. You go through training. You finish training. The first operation you do is a hip replacement. Okay. Are we at that osseointegration? Definitely not. We are at the 60s for hip replacement. So if you want to wait, you need to wait for another 50 years. This technology will crystallize, and we will know a lot of the answers. The good thing is that with what we have done, everything we have done has been measured and properly done to minimize the risk. Of course we are. It's like when you're going to the moon, or when you go into a submarine trying to go to the bottom of the ocean, you're running a risk. And every action has sequences. As long as it's calculated risk, and as long as there is informed consent and the patient have a problem that find a solution for, then that would be a reasonable thing to do. So I don't know many questions for sure, but I know how to manage most of the problems that we are getting at this point in time.
Curious, what risks have decreased the most as this technique for these protocols have improved?
Well, when comparing the first 100 cases that I've done to the 1,000 something that I've done, I think I can say comfortably and confidently that infection rate has dropped dramatically. Okay? Like nowadays, with the way we are doing I mean, again, if you do 2 osseointegration cases or a year is different doing 2 osseointegration cases a day. The experience with them, the more you do. I mean, there are people around the globe that have done handful of osseointegration cases, but there are one handful of people that have done more than 100 cases. And I can tell you, less than 5 people around the world, more than 100. And so, I became comfortable with doing osseointegration after doing my 300 cases. The first 300, I was going on a steep learning curve. But then, am I an expert in it? No, I'm not. I'm far from it. 1,000 cases now, plus I can say that the number of times that I refine my technique is less and less. And I'm doing more the same of what I've done 200 cases before.
Thank you. What does a realistic recovery timeline look from the surgery to daily functions for most patients?
I mean, just published the OGAP 3, and people's misery is some other people's fortune. And this is very sad reality. When wars happen, things develop and advance. Before I had the OGAP 2 protocol, which is single stage surgery and the rehabilitation of 2 phases. On the rehabilitation, so with all due respect to our colleagues that have done continue to develop our rehabilitation program as we go. So initially, I had a single rehabilitation protocol, which was loading over 6 weeks, and then such for 6 weeks, and then recurring with single cuts, and then on a rehabilitation. Then I moved to the 2 rehabilitation program until 2022, where we have the standard loading protocol and the loading protocol. And since the Ukraine war, when I went to Ukraine because of the circumstances, I started treating Ukrainian soldiers, and I developed the OGAP 3, which is the more complicated rehabilitation protocols. And that is 4 programs. So depends on many factors, and I recommend that people read this article because it just came I just published it in the last few weeks. So you have example of patients like Ukrainian soldiers where I put them immediately, no loading. And that is an immediate protocol, and that's only for people who just lost their limb, traumatic amputation, healthy young males, or healthy young females, okay, that are very robust, very solid bone. And this is immediate walking. They walk with 2 crutches until they're comfortable, and then they let go. So their rehabilitation takes this group of patients. The second protocol is the standard protocol, which is doing the operation. 2 weeks later, they get fitted. They go through loading program, where they get fitted with a prosthesis. They walk with 2 after 2 weeks, and then for 6 weeks, and they walk with single crutch for another 6 weeks, and then unaided after. So around 3 months rehabilitation program. This is suited patients who are above knee amputees that have good bone quality. This is suitable for transtibial amputees that we do in the diaphysis of the tibia, okay? Not in the proximal end of the tibia. So they have enough length of the tibia. and that's undoing the amputation on them. Have the loading protocol, and this is involving loading over 6 weeks by increment of 5 kilos every week till they get 50 kilos or half of their body weight until to the 6 mark, and then they get fitted by their prosthesis and they walk with 2 crutches for 6 weeks, one for 6 weeks, and then unaided. That takes around 1.5 months of rehabilitation. This is suitable for osteoporotic above knee patients, patients who have tibial amputation, and patients who have not so good bone quality patients. This rehabilitation is the slow rehabilitation. Then delayed protocol. The delayed protocol is for which involve inserting the implant, waiting for 6 weeks to 3 months without doing anything, and then you load over 6 weeks, and then you fit the patient with their prosthesis, walk with 2 crutches for 6 weeks, crutch for 6 weeks, and then unaided after. That's 4.5 months rehabilitation. This mainly for patients that are lengthened, very short, very osteoporotic bone transtibial amputees. So these are the 4 protocols. These are the patients that, so whoever is listening, you can decide which category you fall under. And it's very clearly delineated. The paper is written in a very layman language that everybody can. It's not very complex. And we are the like fortunate that whatever we wish people follow, and that applies to majority of our colleagues, and you don't need to reinvent the wheel if the wheel is basically so.
Long-term skin and stoma care realistically look like for patients living?
Yeah, so this is again one questions. The answer is I don't know. So what I can tell you is that when I went to Iraq, I was through 21 cases, the first incidents, and I saw 250 cases in that particular trip. And back then, I'd be smokers. And again, as I said, people's misfortune, other people's fortune. And because of the war in Iraq, we looked at all the Iraqi soldiers. So I didn't do any smokers back then. So the first 50 cases I saw, I discounted. And I said, not suitable, not suitable. And then someone tapped on my shoulder and said, well, hang on, if you're gonna disregard every single smoker, you better go pack your bags up because you won't find any non-smokers. We ended up with 180 Iraqi soldiers. 2 were non-smokers, 186 smokers. I noticed is that the Iraqi patient, the lowest infection rates, the best stoma. Now, whether that is because they have very high immunity, they live in a dry environment, they live in the heat, or the smoking reduced the blood supply, or losing, I don't know. But they have the best stomas out of everybody. What we is that people who are below knee amputees, they have much less ooze, less stoma problems. People, the higher the level of the amputation, the more fat, the more adipose tissue, the more ooze, the more stoma issues. But some patients tend to have that is very soft, and some people develop crusting. The stoma heals very quickly. It varies from one person to the other, and people alter based on their body habits, based on dietary, and based on their recreational habits. What we notice is that people who drink beer more, they ooze more. People who take they ooze more.
Okay, so diet does matter. That's interesting. We're like nearing the end of our time, so there are two more questions that Tina wants me to ask. And so after working with amputees around the world, uh, to motivate you personally to do this work.
Look, I'm a strong believer that this technology deserves the standard of care for amputees. And my mission in life is the day that comes before I die, that this people who can't afford it, people need it most in developing countries. And I'm working on America because the only way any kind of technology to become the standard of care will need to be in America. And that is a fact due to the sheer volume of amputees in this country, and due to the, I mean, in America we have number of amputees in America is equal to 20% of the Australian population, so it's huge. Okay, so that's what motivates me. That's what keeps me, and the smile that I see on a child's face when they walk to school with their father or mother holding their hand, walking with them, means the world, basically.
Pretty awesome. What do you wish every amputee knew about their potential, even beyond surgical solutions?
Yeah, I think wish that every person that lose a limb have the. I mean, I have a lot of admiration for people who end up with physical disability. Disability is the disability of the mind. You can be a perfect body, fully able, but completely disabled. So, so that's where I wish and I hope that every person that lose a limb look at the world from that perspective. Is that losing a limb doesn't mean disability, because can open many horizons for you to be much more successful in your life. And it's all about the way you look at things. Half glass full is the way to do this.
Yeah, really, at the end of the day, your life isn't determined by what happens to you. It's defined by week of it.
Absolutely. Absolutely.
Love that.
We could ask you questions all night long. There's so many, like people always want to know if you are you able to run again? You know, there's a lot of misconceptions about like if you do that, you can't run or jump.
I allow my patient to run after a year.
Amazing. So what I'll do, because we do have a lot of questions that have come in and I want to be respectful of everyone's time, I'll send your team a list of some of the other questions that we didn't get it answered, but we just can't thank you enough for the work, for the pioneering in the industry, and for all the lives that you must have just improved so much of their quality. And moreover, for taking the time out of your very busy day to be here to educate and let us come into the world and have your brain in such space. So from all of us, Dr. Munjed, thank you. And to your team that helped to set this up, thank you all. For everyone in attendance, I'm proud of you for investing in yourself and for showing up for yourself today. I hope to see you guys back again. Same bat channel next month at Heart. For all of you guys here, make sure you put your best foot forward. If you don't have a foot, just put your thumb up or something. Take care, everybody. Good to meet you all.
Thank you. Take care.
Bye-bye.